I was asked to speak about epidemiology, which I think all of us really know, but still I'll go through it. And then later I'll give a quick status update on the current outbreak, where I'll take you through where it all began, what it is now, and where we are, and potentially what we need to do. So as in a brief, of course, Robert, thank you so much for the introduction. I appreciate. Ebola virus disease is not a very old disease as we know. It was first identified in 1976. I think this piece of history all of us know. In the twin outbreaks in Congo, then in Zaire, in a place near a small river called Ebola, and another outbreak in Sudan. Then Sudan, currently South Sudan, let's call it Zara. Yambuku called it Zara. At that time, it was thought they were the same disease or the same strain, but later they found out with the technology that they were actually different strains. And also, that's very important as we speak today, because the Ebola Zaire is a different strain, and Ebola Sudan Ebola virus is a different strain, which is currently saturating the parts of Uganda in a few districts, as I would highlight. The first known outbreak of Ebola, which was the Sudan Ebola virus, was in 2000, 20 years ago, with a huge outbreak in the northern part of the country.
I request that the presenter increases his volume, otherwise we're not hearing very well.
Otherwise, okay. Can you hear me now? Is it much better than before?
Oh, you are now better at least.
Thank you so much. So, apologies for that. So, that 2000 outbreak until the West African outbreak was the biggest outbreak of Ebola in the world. But now ranks third after the Congo or the DRC outbreak of 2018, 2020. And we know very well that the virus lives innocently in the wild, in the bats, specifically the fruit bats, where it appears doesn't cause disease. But usually the transition is from the wild into humans happens at a time when there's a breach of that interface, either through a primate or directly when there's an interaction between the bats and humans. And when that wild-human interface breached, the subsequent transmission actually is carried forward through sustained human-to-human transmission, which is basically through body fluids of infected persons. And of course, the transmission...
Are you supposed to be changing the slides because we can only see one slide?
I would send it. I will be changing them in a while.
Okay, please.
I'm just picking up cap for now. So the transmission, we think is a seasonal pattern, as we notice now, which is essentially around the months of July, August, or thereabout. And we're trying to investigate the ecological aspect of this. And of course, but what we know that the fruit bats actually feed on fruits and we live with them. One hypothesis is that this happens at the end of the mango season. And as the mango season wanes down, there's pressure on the fruits. And the fruits are shared by humans, usually children, who bite or eat some of the mangoes that have been bitten by the fruit bats. But that's an hypothesis, which we are working on to actually prove. So as I said, the current virus is Sudan Ebola virus. We've been able to run the whole genome sequencing, and we sit very close to the last outbreak in Nyimbwa, Luwero 2012, and very close to the outbreak in Chibale. We're close to almost 96.6 thereabout. So with that, of course, we know there's no treatment for Ebola virus, and much of the treatment we have is actually supportive. And that supportive treatment is geared towards protection of organ injury, which in our case is basically a protection and rehydration to make sure that we don't have patients going hypovolemia and also subsequently having renal failure because as a result of that fluid loss through vomiting and diarrhea and perspiration as having temperature, which a consistent feature from the very beginning up the very end of the illness. So basically, that's a bit about the general disease. And there is a vaccine for a Zaire Ebola virus, but for the current virus strain, we don't have a vaccine. Though later, as I will speak, I'll highlight the efforts that are going on to test some of the molecules that have been developed elsewhere for this. So basically, I'm going to run you through still the outbreak as it is today. It's a mosaic. Basically, we do think the transmission happened a little bit as far back as the beginning of August. We think around 6th or 7th August, where we have 2 individuals at that time, as I will show later in the transmission tree, in the transmission chain, had symptoms. And we think these 2 individuals had a common source, but we haven't been able to find that common source. So those 2 individuals between 5th and 6th actually set up multiple clusters, which clusters I'm displaying here as 3 clusters: cluster A, cluster B, and cluster C, which we are following. There are subsequently other small subclusters, like a small hospital cluster, which I'll speak through later, which in Mubende Regional Referral Hospital. So that is basically a cluster in Chegegwa, which actually a detachment from the original cluster A of the patients that came from Madudu sub-county in the Mubende district, where a patient having relatives in Chegegwa, but living with parents in Madudu Mubende district was sick, and then subsequently moved and took the illness to Chegegwa, setting up that cluster. I just want to show you this messy mosaic of transmission, just to demonstrate what happens, seeing the red dots, that the cases, and the contacts out of them. And the idea about the contacts is basically for us to be able to know what they are, define the transmission chains, and we deal with these contacts in such a way that we quarantine them, or we ask them to stay home, isolate themselves from their relatives, and follow them up for 21 days. 21 days from the date of their last exposure. And this is where we're seeing the cases and the contacts. But what is important, and I want to clarify, are the clusters as they move. The original cluster, as we see here at the beginning of August, and that gave birth. Some of these individuals, we could have lost them and we couldn't trace them. And these are the individuals dead, and we classify them as probable. So we also see all these transmission lines, which we have been able now to close and understand that the contacts arising out of them. And we are following them. And of course, a big number of them have been followed up, and some of them have been actually discharged from the contact list. Again, the cluster B linked to a facility. That is a facility, a private facility, I will not say the name, in Madudu sub-county, where actually we think there was another amplification in a health facility setting where we have one of our health workers working there. Again, there was a source of transmission to other patients, setting up all these lines of transmission as we see. The well-defined cluster, of course, the Chegegwa cluster, which of course now we think Oops. So the Chegegwa cluster is a well-defined cluster. Is a well-defined cluster, which we think now we are very close to closing with the very well laid out contact tracing, and we've not had secondary transmission happening there. And now we are moving the third week with no secondary transmission. Now we think we may soon close that cluster. So in terms of numbers, we have 44 confirmed cases. In the last 72 hours, we've had one confirmed case, and that case came from, again, Madudu. We have not had a case in the last 48 hours before, and of which we have 10 confirmed deaths and 20 probable cases. The cases that I showed you earlier in the earlier transmission tree, where we were unable then to unmask the outbreak before we unmasked it. So this is the distribution of cases in the 5 districts: Mubende, the epicenter, Chegegwa, where of course we had secondary cases. Kasanda, of course, secondary transmission. Kagadi, again, a health worker moving from Mubende, went into Kagadi, presented with symptoms and subsequently died. And then Bunyangabo, also a health worker that moved from Mubende and moved back home. So this is the current temporal distribution of cases. Here, the combination is of both of the confirmed cases and also looking at both the probable and the confirmed cases. The red are the dead. 10 deaths that have happened in the last 2-3 weeks since we declared outbreak, starting with the index case for this. So the 20, and this is very important, the 20 probable cases, the 40 confirmed cases, bringing what we think the caseload to 64 by now. So again, a demonstration temporal distribution of cases starting in Movenda, which is the epicenter, largely in one sub-county, Madudu, but a couple of sub-counties a couple of sub-counties in Movenda affected. Again, the first transmission first happened in Chegegwa. Then later we had Kasanda. Then we have Kagadi, and the last entrant is Bunyangabo. Bunyangabo is quite far, as I will demonstrate later, and I will show that this is the result of a hospital cluster where through a single procedure, we had a couple of colleagues exposed in what we think was a very big inoculant, given the fact that the procedure they were doing was an invasive procedure. Of note, all these exposures for health workers really happened before we unmasked the outbreak, before anyone knew what we were dealing with was Ebola. And the case age groups affected, but principally younger adults, between 20 and 40 years about. And initially, it was actually younger age, children and women. And now we have a transition to nearly all age groups. Now, looking at the distribution of the cases, confirmed cases, as I said, largely from one sub-county, but also other sub-counties here in the Mubende district and Chegegwa. Excuse my maps, because the Bbosa has not given us new maps for new sub-counties. So some of the sub-counties here actually can't be able to demonstrate. So the movement in Bunyangabo from Mubende is a health worker who had been exposed, moved to his home in Bunyangabo, developed symptoms, and then came back to Kabarole. He's currently admitted in Kabarole treatment center, a hotspot treatment center. Kagadi, again, as I said, the health worker who moved from Madudu here, we are seeing 15, and when treated in Kagadi, that's where he died. Chegega, this is the cluster C, and then also another small cluster in Kasanda, where we have one probable case and one confirmed case. So of note, colleagues, the concentration of transmission for now remains largely in one district, that is Mubende, and to be precise, that is Madudu sub-county, where much of the activities that are taking place are as of now. So, colleagues, of course, this is another messy map, but of course, to show the distribution of these cases in relation to the whole country, seeing, and of course, to capture, also to show you the extent of dispersal within these areas. So again, to show that in the last 7 days, most of the cases are coming from mainly Mubende districts, Madudu, Chiruma, West Division, Bbosa, and Rimi Bunyangabo, the case of the individual that I've spoken about. So again, to show, of course, one of the major interventions in the control of Ebola is definition of the transmission chains, being able to identify contacts, follow them up, and be able to pick cases as early as possible. And how do we do this? We identify them, we get in touch with them, we quarantine them, self-quarantine, this is not institutional quarantine, in their homes. And then our teams will follow them up on a daily basis for specifically two things. One, whether they have developed symptoms, and then we do a temperature measurement. In other situations, we may leave them with a thermometer, usually a glass thermometer, which is easily disinfectable, and they measure the temperature themselves. Sometimes if the numbers actually overwhelm us of contacts, then we may not follow them on a daily basis, but we call them to find out if they have a temperature. But our current circumstances, the numbers of contacts are actually manageable, and we are able to follow them through. So again, to show you, these are the contacts in Mubende. The number of contacts rises and drops. This is not strange because we reach more contacts every time we have a new case, but every other day, the moment we have individuals dropping